This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, let me take you through a very interesting case where I could notice very interesting changes in the posterior capsule, which is not very uncommon, but it was very nicely appreciated in this case. That's the posterior zonular weakness and how it appears on table. I made a similar video titled the PC trampolining. The links are given in the description. Please have a look at that video as well. Now, here is a 75-year-old gentleman who is undergoing cataract surgery. Patient is slightly myopic. This is the IOL power and the ocular biometry status, and the initial steps are alright. When I'm trying to do the rexes, I don't find any exaggerated zonular weakness here, although it's not very strong, but it was relatively manageable. So the hydrodissection is done and I'm trying to rotate the nucleus. It is slightly difficult, but the moment I keep my chopper in the mid-peripheral region and then rotate it rotates quite easily. So the anterior zonular health was reasonable in this patient, although there seems to be a generalized zonular weakness which can be expected in these age group patients. Now the nucleus management is being done. The nucleus is slightly dense, so I'm going to be a little bit slow, and the nucleus is broken down into many fragments and then aspirated out. I'm using a repeated bolus of OVD to protect the endothelium and keep the capsular bag and the antechamber formed as the nucleus is being emulsified. So once the nucleus is emulsified, time to aspirate the cortex, and before that I usually, as a routine, I flush the posterior capsule with BSS so just to loosen out some of the fibers which could be sticking onto it. I noticed that there is a wrinkling of the posterior capsule. Maybe it is marginally much more than what I usually see, and I'm filling the bag with OVD, and this is usually customary for me to fill it before I proceed with cortex aspiration, just to add a layer of safety. And as the first few cortical fibers are being aspirated, everything looks fine. But as the OVD is getting evacuated from the bag, I get a sense of positive pressure. It looks like the posterior capsule is being pushed anteriorly. Well, this could be possible because there could be some amount of fluid misdirection which is trying to push the posterior capsule forward, because the fluid would have gone behind the posterior capsule, and in the presence of an anterior hyaloid detachment, it's possible that it can circulate behind it quite easily and push the posterior capsule anteriorly. I want to come out and try to reassess the situation now. The first chunk of cortex is out, and as I try to go in a little deep into the fornix, the bag gets caught in the aspiration port quite easily and is trying to come out. I push reflux and I disengage it, and as the IA cannula is removed of the eye becomes soft, and suddenly we can see this classical wrinkling of the posterior capsule. It is more prominent in the distal half. Only the distal half you can see these wrinkles which are extremely prominent. This demarcation line can sometimes mimic a posterior capsule tear. A novice surgeon can get confused because of this, and one way to distinguish them from a weakness of the posterior zonules is to put in viscoelastic into the bag, and immediately these folds disappear. The wrinkles gets ironed out, and this is a sign that it was a pseudo tear-like appearance, but it was primarily because of the wrinkling of the posterior capsule, which was secondary to the weakness of the posterior zonules. So the solution to this is always try to work with the bag very well formed. So I'm going to inject OVD, which is going to push back the posterior capsule, straighten out all the wrinkles in the bag, and then I'm going to venture to remove this remaining cortex. I'm just trying to flush the posterior capsule to clean off some of the fibers, but we can see that the wrinkling in the posterior capsule is so exaggerated. We can see multiple dot-like opacities behind the posterior capsule in the Berger space. These are all indicative of the fact that there is probably an anterior hyaloid detachment, and fluid has got access to pass from the antisegment to behind the posterior capsule in the Berger space. Time to implant the lens, but at this point I'm wondering, should I insert the CTR now itself and then place the bag? The posterior capsule looked very thin and flimsy, and my concern was there an increased risk of rupturing the posterior capsule during insertion of the CTR. It was unlikely, but because the anterior zonules were quite healthy, I thought I could defer and see. This lens which I'm going to inject is a single piece hydrophobic lens, and I decided to go ahead and inject the lens first and see how it sits and is there any decentration, and then I'll take a call on CTR. With the bag being inflated with the OVD, the lens is gently manipulated into the bag. It looks alright now. So I'm going to remove OVD both in front and behind the lens and then see whether the lens centers well or not. And even after the OVD is removed, the lens looks to be fairly well centered. And because the anti-zonules and the bag in general looks very healthy, I've aborted the idea of putting in a CTR, and it looks fine. And in the post-op period also, there were no issues. The patient continues to do well. So to summarize, posterior capsule wrinkling and trampoline of the posterior capsule is an important sign of posterior zonular weakness, and this has clinical implication that if you don't recognize this and take adequate measures during cortex aspiration, like keeping the bag formed with probably viscoelastic, there is a higher risk of causing posterior capsule tear, because invariably we're also going to have positive pressure because of the fluid misdirection which can happen because of the compromised zonules, and the PC is always pushed forward. So it's critical to identify these subtle changes, and if required, putting in a CTR would definitely aid the procedure, but being very gentle in cortex aspiration is very helpful to minimize the occurrence of posterior capsule tear in such eyes. Similar videos on the different ways the posterior zonular weakness presents and the anterior zonular weakness presents have been made by Dr. Kumar, doctor from Mumbai, and Dr. Saurabh Patwardhan from Sangli. So please do check their videos on this topic as well. So that was it. Thank you for watching and hope you found this helpful.